on the mesials and they can't reach it in protrusive, again, think crossover. All right, so let's start with the most common movement pattern, the one that you're probably going to see every day, almost on every patient it seems like. Somebody that's edge to edge, okay? Somebody that comes out and wears their teeth in an edge to edge position. So I'm going to use this patient to illustrate edge to edge. This patient is always on the edges of his teeth. All right, always. Doesn't even spend much time in MIP, but always plays on the edges protrusively. I didn't treat this patient. Frank treated this patient. The reason I didn't treat this patient is the patient's me. All right? If you spend any time around me and I'm not talking or eating, you'll see masseters firing because I'm on my anterior teeth. All right? And as a result of that, you're going to start to see the wear pattern that's been created. So you can start to look at the edges, the way they chip. If you ask me to go to my favorite position, it's not hard to find. I'll go right there. You can see the lower canine fits in really nicely. Okay? So when we see somebody who has protrusive edge-to-edge wear, what does it mean to me? Okay, I'll tell you, it means a few things. The first thing that it would mean to me is they're probably going to go back and do this again. But what it means to me is that I think that this is a daytime activity, a daytime behavior. It's not done at night, it's done during the day. And you say, how would you know that if you don't know the patient? You all make night guards, right? You make night guards for patients. They bring them back when you do dentistry so you can check to see if the occlusion still fits or if it still fits in the mouth. What is the wear pattern you see on night guards? Where does it go? It goes left and right, like almost exclusively. Have you seen a wear pattern on a night guard that comes protrusive? Because I haven't seen that. You just found the unicorn, right? It's special. So she would take some photos of it and send them to me so I have those photos because I don't have them. But the reality is I'm going to ask you a couple of follow-up questions. How do you know the patient was asleep when they did that movement? All right? Do you think you put your night guard in and your head hits the bellow and you fall asleep? Could it be that you put the night guard in and you lay down and you're thinking about your day, you're thinking about tomorrow, and now you're moving forward on it? Or you wake up at 3:30 in the morning and your mind starts racing and now you're moving forward? Right? Just because it's a night guard and it's at night and you're in bed doesn't mean you're asleep. Because the movement pattern at night is left and right. So then when I see somebody protrusively coming out edge to edge, why would I think anything other than it's a daytime activity? So now the question is why? Why do they do it? Two reasons. One could always be explained with airway, right? Got to breathe during the day. If I bring my mandible down and forward, I can breathe maybe better. The second one would be stress and anxiety. There's research to show now that when you clench on your anterior teeth, you're actually de-stressing yourself because it feeds back and it changes the release of corticotropin releasing factor. It changes the release of cortisol into our bodies. Cortisol is a stressor. So clenching on anterior teeth actually does de-stress you, but it's a daytime activity. So how are we going to design an occlusion for somebody that we know is going to go back and do this? It's going to come back into the edge-to-edge positions. Well, let's go back into classic occlusal theory. Right? And this is the way I was trained. In my PROS program at Washington, it didn't matter if you were doing a full rehab or you're doing some anterior teeth. Everybody occlusally was managed the same way, which would mean that we had this belief that everybody should be in a fully seated condylar position, which is not a belief that I think is true now. So we would equilibrate every patient that we treated. All right? We'd equilibrate until the anteriors touched with the condyle seated. We would have them move left and right. We'd take away any posterior interferences. Then we'd equilibrate lateral and protrusive pathways on the anterior teeth. We would do crossover. We'd check everything. We'd bring them back. We'd check it again. And then finally, we get to restore them. And everybody was managed the same way. So, given that that was 25 years ago, what do we believe now? Because our thought processes have changed. Current thoughts would be on a patient like this, first thing I would do is I wouldn't equilibrate this patient. This patient never goes back into CR. In fact, they really don't even spend much time in MIP. So we're going to treat the anterior teeth. We're going to leave the existing occlusion as is. So the first thing that Frank is going to do is he's going to use composite, which is what my preference was, bond composite to the anteriors. So he did one central, he's going to do the other central, then he's going to do both laterals. Okay? So there he is, that's done. Now, if you sat me up and let me walk away, my occlusion was fine. He didn't change anything, he added to the edges. But that wouldn't have lasted. That wouldn't have lasted for the rest of the day. I would have broken something. So what's our first occlusal aspect? The occlusal adjustment process for me only starts in the same position, no matter what I'm doing. It starts with edges. Bring the mandible down and forward and adjust the edges on the upper and lower anteriors. Okay? Now, you know you're going to have to adjust those edges. They used to fit together really well when there was anterior tooth wear, but now that you've changed the aesthetics and the positions of the upper anteriors, it no longer fits against the lowers, right? So you know that you're going to have to come back in and do some plasty of the incisal edges of the lower anteriors. You know it from your exam. So I actually take the exam as an opportunity to tell the patient what I'm going to do when I treat the anterior teeth. So if you were to examine me, if I was examining myself, what I would say is, when I get done lengthening your upper teeth and fixing all of these wears and all these chips, I'm going to polish the edges of your lower anteriors, right? And you have to use the word polish, right? Polish. I'm going to polish them with a diamond burr, but I'm not going to tell them that. Because if we don't set the intention that we're going to come back and adjust it, when you drop a burr down to lower anteriors, they go, whoa, 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 what are you doing? Oh, I have to. You see, what edge-to-edge wear patients need is they need force distribution. I need to be able to spread the force out over bigger surface area and maybe pick up more teeth. And the only way to do that is to plasty the anteriors, right? Set the aesthetics of the upper. Your first adjustment is edge to edge, and you're going to plasty the lower anteriors. Okay? Once you do protrusive edge to edge, you go left lateral and right lateral in an edge to edge position, right? I'm not looking at pathways, just go right to the edges. So here, notice the lower canine. If you didn't adjust the lower canine edge, it's going to wipe that lateral out. Okay? So we plastied the lower canine. You can see how much he's plastied the lower anteriors. Now, depending on how much you need to adjust the lower anteriors, you may now have done this. You've lost your centric contact. Okay? So first part of the adjustment is edges. Protrusive edges, left lateral, right lateral edges. Next, you're going to come back and you're going to adjust your centric contacts. Now, in this case, there is no centric contacts because he had to plasty the edges so much. So general rule, if somebody comes in and they actually have anterior coupling, the teeth touch, they should leave with anterior coupling. Because the risk would be if you don't, things are going to erupt and move until they touch. And when they erupt and move, your adjustments that you've already are no longer valid. So how do we obtain our centric contacts? You have two options. You could equilibrate the patient, right? Seat the condyles and equilibrate. Adjust all the teeth until the anteriors come in to contact. One option. Next option would be you already have composite out in your hands. What if you just bonded composite to regain your anterior contact? Okay? Both options can work. Think about the classic occlusal approach though, right? Let's say that you took me and you equilibrated me before you did anything. And then you restored the upper anteriors, and when you adjusted the lower anterior edges, you end up with an anterior open bite. What do you get the luxury of doing again now? You get to redo the entire equilibration. So the order in which we do things needs to change, but it's all started with the anterior tooth adjustment. Lastly, you would adjust the pathways, right? Pathways from centric to the edge-to-edge position. And when you adjust the pathways, you try to adjust the pathways at the expense of the palatal of the upper, all right? Because if you do a lot of adjustment on the incisal edge of the lower, you run the risk of actually removing the contact that you created in edges and centric. So then what's the limiting factor on how much I can actually plasty the pathway on the upper? It's thickness, right? Most materials do well at 1 millimeter of thickness. You start getting less than that, you start thinning out the palate of the upper, and you start to become less than that, you won't be able to use a material that has good substantivity. It'll be too thin. So if you do have to adjust lower anteriors, you do it at the expense of that little green line, the leading edge. The leading edge, then it still remains with a nice edge-to-edge contact and a nice centric contact. Okay? So what did Frank choose to do? Let me back up here. What did Frank choose to do? Did he choose to equilibrate me, or did he choose to add composite? He didn't do either of those. He left me with an anterior open bite. All right? So what did I just tell you, though, a second ago? What shouldn't you do? If they come in with anterior coupling, they should leave with their anterior teeth touching. But he left me this way. All right? So what was his hypothesis? That if I spend all this time on the edges of my teeth, that should keep the teeth from moving and erupting. But his hypothesis was wrong, because my teeth touch now. But what happened in the process of them going from here into where they're touching? They moved, right? Lower anteriors moved, maybe the upper anteriors moved. And when they moved, the adjustment that you created on the edges, the most important aspect for an edge-to-edge wear patient, no longer fit together. So what do you think happened? I broke composite, right? Chipped composite. So, chipped it. Frank, I need you to fix this. He fixes it. He adjusts the lower again. But if there's no contact, teeth are going to move. I broke it again. So I broke it 3 times. The last time I broke it, now the teeth are actually in occlusion, and now you have stability, and I never broke it since. Okay? So if they come in and they have centric stops on the anterior, they should leave with centric stops. That being said, you might find patients in your practice that come in with an anterior open bite, right? The teeth don't touch. That's a different patient in my mind, right? I still might try to obtain anterior coupling because it helps me disglued back teeth, helps me protect back teeth. But also that patient now shows me they have a history of being able to maintain the anterior open bite, right? Typically there's something there, probably a tongue, that's holding that anterior open bite present. Now I know that if I kept it there, I know it's going to stay there. So different patient. They come in with contact, they should leave with contact. Okay, so here's the final restorations, and this is probably now, I'm going to say probably close to 50 that I've actually had this composite. Right, composite's a great material, especially on an edge-to-edge wear patient, because composite's all loaded under compression. It does really well under compression. Okay, let's take the edge-to-edge patient, but now instead of doing it directly, imagine somebody you're going to do veneers on or crowns on. The same thought process has to be applied, but the order in which you do it now might change. Right? So think about how you traditionally restore somebody and do veneers. You prep, you impress, and you make temps, correct? Is that the order you follow? Yes? Okay, now imagine you have to now adjust the lower anteriors, and in your process of adjusting the lower anteriors, you're adjusting them against your upper temporaries. And if you lose your centric contacts, you got to figure out how to regain contact. And one of those options was change the design. Maybe you change your prep design. The other option was you do an equilibration, in which case you'd kind of like to know which option you're going to do, because it's going to change the order in which you treat that patient. It's going to change your prep design. Or maybe it's going to change that I would have to prep, make temps, and then equilibrate before I made my impression. Does that make sense? Okay, so let me use this patient as an example. This is a dentist who doesn't like his anterior teeth, doesn't like the facets. And you look at this and go, it doesn't look like this is a big facet patient. But I'll tell you that all of these different edges, that's not how the teeth are naturally made, right? Those are all facets that are created by some movement pattern that the patient is doing. And they're all edge-to-edge facets. But let me draw your attention to his right canine. Do you see the facet on the right canine? Do you see the orientation of it? It's not completely flat, is it? It's more beveled out towards the facial. So that facet there, I would say, would be a crossover facet. Okay? Crossover is just a bigger range of motion. You don't go just edge to edge, your lower canine goes well beyond it. Right? Now, the nice part about working on dentists is it's easy to get them to move into different positions so you can photograph it. Right? You just say, go into protrusive, go left lateral, go. You tell that to a patient, go move your jaw to the left. They say, you want me to move my upper jaw to the left or my lower jaw? Let's just do the lower jaw now. So when we evaluate our wear patients, I want to confirm the different positions that they are moving to create the facets that I see. And sometimes you might find patients where they say, well, I can't move my jaw left. I can only go right. Right? So then we might have to make some casts and put them on an articulator so I can actually see and confirm the positions that they're going to. Because I'm going to make an assumption. And I think this is a very safe assumption to make. Whatever they've been doing to their teeth, why they're doing it, assume that they're going to go back and do the same thing. Right? So if you fix the etiology, you're safe. If the etiology isn't fixed or it comes back, I still am safe. So I confirm all of these different occlusal positions. Here's right lateral, edge to edge. You can see the centrals and the canines touch. When we go beyond that, now where it touches is the centrals. Okay? So what was the steps that we did when I showed you my case? We first changed anterior tooth position, and then we did all of our occlusal adjustments from that. So we're going to follow the same ideas if we're going into an indirect restorative method. In this case, it's going to start by changing anterior tooth position, changing the edges, but instead of just building the teeth up with resin, we're going to do it in a diagnostic wax-up. All right? So have a technician do this, and you can do it in the analog world, or you could actually do it in the digital world and then print a model. Each way works perfectly fine. But I would actually now want the technician to send me this back. Okay? So I'm the technician here, so I'm going to do this myself. But even if you're not doing your own diagnostics, you want them to send you the case back. Because the next part, the occlusal adjustment part, is going to be done diagnostically. It's like a trial equilibration, if you will. I'm going to go through those exact same positions, protrusively, edge to edge, lateral edge to edge, centric contacts and pathways, and I'm going to design everything here. Okay? Why is that important? Because I'm going to do it clinically, and depending on what happens to the lower anteriors, I might lose centric contact, which would mean I want to know that so I can actually charge them for the equilibration. If I lose centric contact and I don't want to equilibrate, I want to change my preparation. I want to grab farther down the palatal of the upper anteriors to regain my stop. Does that make sense? So I would want to know that before I actually get to the chair with the patient. Now, let's say that we wanted to do an equilibration. You couldn't do the equilibration until you changed the upper anteriors, right? Because the process starts with edges. But it's really hard to do this on veneer temps, isn't it? So if I was going to equilibrate this patient, I actually wouldn't prep the teeth to begin with. I'm going to bounce out of this case and show you a different case. Here's the way I would manage it. You do your diagnostic wax-up. Here's an edge-to-edge wearer patient. Here's the wax-up. You would go through on the diagnostic casts that are mounted, and you would do your trial equilibration, right? And it would start with the edges in your adjustment. So when I got back to the mouth, I would actually use the wax-up, and I would actually mock the anteriors up, right? So go ahead and etch the teeth, put some adhesive on the teeth, and then just use your provisional material and either a putty or a copyplast matrix, and you're going to do a mock-up. Now, the mock-up is traditionally to show the patient where you're going, right? The mock-up is also a prep reduction guide, but from an occlusal standpoint, what's the big benefit? I can now use this mock-up to do all of my occlusal adjustment of lower anteriors and even a full equilibration if I wanted to. Patient's not numb, it's the position of the teeth that I desire, and I go through the entire equilibration piece before I even actually prep the patient and give any anesthetic. And then once I'm done, Then I can use it as a prep reduction guide. So all of my veneers, I can be more minimally invasive and have the same thickness of material removed. Right? So there's more than just the motivational mock-up aspect, more than just the prep reduction guide aspect. There's the ability for me to design the occlusion before I start restorative dentistry. So when you get into the positions of doing your occlusal adjustment, it's going to start the same way. You start out edge to edge. So what you're going to see here is you're going to see on the left screen is the movement position with the teeth untouched, and on the right screen is the same position with the provisionals fabricated. So you can see if we didn't adjust the lower anteriors and polish their edges, all the contact's going to be on that one tooth, the distal of the central. So what's the goal? The goal is force distribution. I don't want small point contacts. I want the force spread out. All right? So we do edges protrusively, and we do edge-to-edge left lateral and right lateral. So here's the patient's crossover position. Here's the same crossover position in the provisionals. Okay, so what's the goal with crossover? The goal with crossover is that when you have them in a left lateral edge-to-edge, I want to see the canines touching, obviously, but I also want to see the centrals touching. All right? I need to see the centrals touching as well. Why is that important? Because now imagine what's going to happen if the patient moved farther left. If the canines were the only two teeth touching and they moved farther left, they're going to fall off the canine, and then they're going to ram into the centrals. And when they come back into their occlusion, they're going to run into the lateral facial surface of the canine before they can get back into their occlusion. If you adjust it so when they come out into their left lateral or right lateral edge to edge, that the canines as well as the centrals touch, now what happens when they move farther? It hands it off to the centrals, smoothly hands it off. And then when they come back in, you have canines and centrals, and then they can fall off. So you can have canine guidance as a sole canine guidance. When you get to the edge to edge, pick up the centrals. Hands it off to the centrals, comes back in, they have both touching, and then it's canine guidance. Right? So we'll do the same thing in left lateral and right lateral. So you can see without minimal adjustment on the lower, the canine on the right side touches, the centrals touch, and if he moves farther, it just hands it off to the canines. That's a crossover adjustment. Okay, and then we would actually regain our centric stops, either by doing the equilibration, which we would have already done in our mock-up, or we've picked up the contact we would need in the restorative design. And I would know that all from my diagnostics. And then the last piece would be the pathways. Right? Okay, now here's the case on the model. And maybe you've done this, because I've done this. Have you ever worked on a patient that has all these different wear facets, and you tell your technician, you need to really dial this one in, right? I've spent a lot of time clinically dialing the occlusion in, so you need to do the same when you get the case on your lab bench. The problem is this: the articulator doesn't move the same way that the patients do. So they can do it to the best of their ability, but when I get the case back, I actually have to go back in and do the exam, evaluation, and possible adjustment to be able to check things and then do minor refinements. Okay, so here's the provisionals when the patient returns. The key with veneers for me is you need to have nice fitting provisionals so you can actually obtain nice gingival health, right? And nothing worse than taking off temps, the tissue starts bleeding, and then you're trying to bond in some new veneers. It makes for a tough day. So when we make our veneer provisionals, I make them indirectly. I'll make them, I'll pop them off, I'll trim them, I'll polish them, and then I actually cement them on. And when we cement them on, I want them to stay on, right? I don't like going in the office on weekends or at night when I'm not supposed to be there. So how do I get veneer provisionals to stay on? I actually do a few things. I'll actually etch, right in the middle incisal, etch about a 2 millimeter diameter circle, right? Little spot etch. Depending on how concerned you are about them staying on, you might put a little dot of adhesive in each of those etched areas. So sometimes I put it on, sometimes I don't. And then I actually use my permanent cement. Not Temp-On Clear, not Neotemp, my permanent cement. And I would use that as opposed to using a flowable, right? The difference would be veneer cement I can tack, right? I can tack cure it, and then I can do my cleanup. Flowable composite's either cured or it's not. So it's much more challenging to clean up any excess. So tack cure it, clean it all up. I can keep them on most of the time, right? They still might come off, but again, it's a very, very small number. What's the only downside? Getting them off when you're ready to remove them, right? So typically you end up having to break them off, right? You make a cut in it and you start chipping them off and they start flying around the operatory, but that's okay because I'm going to throw them away anyway. Now, if these were crowns, I would actually temporarily try the crowns in. And I would try them in using something like Mach 2. Mach 2 is a disilicone from Parkel. You'd put a little, again, 2mm dot onto the intaglio surface and seat it. It actually holds the restoration in place, right? Because have you ever tried to adjust an occlusion with a bunch of ceramic crowns and they all kind of start wiggling around? So you can't actually adjust an occlusion. You can hardly adjust interproximal contacts. If you try them in with silicone, everything stays really snug, right? Patients can do all of the different occlusal positions and they're actually almost like they're cemented, but they're not. Here's a little advisory. Do not use Mach 2 to try in veneers. Do not. The reason is, it actually, if everything's nice and dry, it'll hold the veneers on so well that you can't get them off. And then when you get them off, you risk breaking them, right? So great for full coverage, not so great for veneers. The veneers you actually have to put in. Now, you have to go through the same adjustment positions in the same order once you get the permanent restorations in. So where does it start? Edge to edge. Bring the patient edge to edge. And what are we looking for? Force distribution, okay? So tiny contact on the patient's left central. I want the contacts to be broader, right? Tiny contacts mean there's an awful lot of force in a small area. The risk is something chips. So I need to spread the force out, bigger contacts. Before, what we did is we adjusted the lower anteriors. Now what do we adjust? Now you're going to do an adjustment, but it's such a small adjustment, I'm okay actually adjusting the incisal edges of the uppers, okay? But when you do, don't adjust it with a burr, right? Because by the time you get done taking the scratches of the burr out, you've changed the aesthetic. But if you think about how restorations are fabricated, the last thing that the technician typically does is they'll stain and glaze it. And sometimes they have to put on a glaze paste, depending on how the restoration is made. The glaze paste, if you looked at it under a microscope, it's got little undulations to it. It's not perfectly smooth. So take a silicone polishing wheel and polish the edges to true it up, to spread the force out, okay? Now, if you look at left and right lateral, do you notice a problem? This is right lateral, edge to edge, centrals touch, canine touches, everything's perfect. But look what happened on the left side. The canine is the only thing touching. And what's the risk of that? The risk is, we already saw that he goes into a crossover, so now he's going to fall off the canine, and when he comes back in, he's going to run into the canine. So the question is, what do you do? Which one do you adjust? Do you adjust the lower canine? Do you adjust the upper canine? In order to figure out what to adjust, you first ask yourself, do you like the position aesthetically of the upper tooth? Because if I look at the provisionals and I draw this line and I slide that line over, the technician lengthened that canine. Now the question is it better where the technician put it or is it better where I had it in the temps? So that's your first evaluation. If it's better where it was in the temps, then you adjust the, and when you do, your occlusion is going to drop back down. If you like the upper canine, now your adjustment is at the expense of your lower cuspid, in which case you may have to take off so much that when they go back into their centric contact, you no longer have any canine coupling. So then you'd have to bond composite, right? So luckily, the one you want to have is that canine looks too long. It looks a little vampire-ish. So plasty the edge of the canine, make it look like the other canine, and all of a sudden your occlusion gets back into the positions that you desire. All right? So edge-to-edge patients are actually quite predictable, whether you're doing them out of resin or you're doing them out of ceramic. But you just have to be able to ascertain who are our edge-to-edge patients. Right? And then they're going to continue to do it. They are. All right, let's move forward. Patients don't understand that sometimes you're only supposed to have one wear pattern. Oftentimes you might have patients that are edges and pathways or edges and crossover. Okay, so pathway wear. Again, pathway wear, palatal facets on uppers, facially inclined facets on lowers. Right? This is a classic example of a pathway-only wear patient. Look at how worn the facials of the lower anteriors are. It's not a bevel, it's the entire facial. In fact, the teeth are worn flush with the papillae. So, palatal of the uppers, facial of the lowers. This is classic pathway wear patient. Now, when you see a pathway wear patient, what does it mean? To me, it means a couple of things. From an occlusal design standpoint, I need to give them back more freedom, more room, right? They wear themselves into 100% overbite with virtually no overjet. So I actually need to give them back more overjet. Now, when I say more overjet, I don't want you to think that I'm creating an anterior open bite. I'm not. But if this is their guidance pattern and this is the palatal of the upper, I want to create my stop, but give them back more room, right? More freedom. So they need more overjet. Now let me ask you a question. If you have a pathway-only wear patient, okay, like this person right here, and you redesign his anterior relationship and you give him back more overjet, what if you wanted to lengthen the anterior teeth on the upper, right? You wanted to lengthen them from an aesthetic standpoint, which would mean that you're making a deeper overbite for the patient. All right, so my question to you is that a risk? Are you risking things breaking by making a deeper overbite on a pathway-only wear patient? And the answer is no. Pathway-only wear patients are actually the most predictable wear patient to treat. They are. They're easy because their movement pattern is so narrow. It's vertical, right? If you listen to John Coyce, you'd say they chew like a rat, right? Up and down. So as long as you give this patient back overjet, freedom, you can lengthen the upper anterior teeth because the reality is he has 100% overbite. And absolutely no overjet. The teeth are paper thin, and yet they're not breaking. They're not breaking because he doesn't come out and cross the edge. He just goes vertically. So this is the one patient you want to make a deeper overbite, you're totally fine. Just make sure that you give them back overjet, okay? So I know I need to give them back overjet. What's the other thing that I think of? And again, it goes back to Airway. All right, I had the privilege of working with Jeff Rouse. Jeff commuted up to Seattle. So for 2.5, 3 years, we practiced together at my office in Seattle. So he had to get on an airplane, fly 4.5 hours to go to work. So my 35, 40-minute commute, I could no longer complain about. But what I appreciated by spending a lot of time with Jeff was how Airway is such an integral part of our diagnosis and treatment of our patients now. So when I see pathway wear patients, I also think, could it be an airway issue? Right? Why do they have this palatal wear on the upper anteriors? And Jeff's response would be, if you have somebody with missing teeth, constricted arches, transverse issues, right, maxillary deficiencies, their intraoral volume is small, which means that their tongue and a big chunk of food in their mouth, they're going to have trouble trying to chew it and still breathe, which means that they chew differently, right? They chew faster and they chew with a greater range of motion. So greater movement pattern allows there to be more room in their mouth, allows them to continue to breathe. But it could also create a lot of wear patterns. Right? So when I start to see somebody who has pathway wear, they need more overjet, but could it be explained by airway? It would force me to look at that from a screening standpoint. Okay? Now, let me give you a clinical problem I get sent a lot of dentistry that maybe didn't work the first time. So now you're treating a patient who's already failed somebody else, and maybe they're a little disgruntled, so that's not a good mix, is it? So this patient comes in to see me, referred by the dentist that treated her. These veneers have been in place 3 months, okay? 3 months. It's hard to see from the photos, so I will illustrate with some lines all of the different cracks she has in the ceramic in 3 months, okay? Now, when I talked to her, I said, what did your teeth look like before, right? That gives me a better idea kind of about what maybe happened. She goes, I had some composite veneers. She goes, I had these composite veneers for like 16 years. The composite veneers worked. And the only reason I changed them is because they started to discolor and I wanted them to be brighter. So 16 years, composite veneers working no problems. Color's an issue, so she changes them into ceramic, and in 3 months she breaks basically all of them except one. In fact, when I talked to her, she says, yeah, I broke the first one the night I got home, right? So the referral that was sent to the practice was, here's the ceramic system, and here's how I bonded them in, right? So don't use either of those, because obviously it doesn't work. Okay, so what happened? How can we determine maybe what happened? And this is actually a useful talk later about trial therapy. You're going to do a new occlusal design, a new anterior relationship, and the question is it going to work or not? You don't know. You don't know until you try it out. You make the changes and see how they respond to it. So their trial therapy now is in ceramic. It's expensive trial therapy. So when trial therapy fails, how can we use that information to help us correct the problem, right? So here's the question that I would want you to ask yourself. How many teeth failed? How many teeth broke? Right? So they did six anterior teeth, and they had 5 of them break. If you restored 6 teeth and they broke 1, that means something different than breaking them all, okay? So this is a patient of mine. I am only going to restore 1 tooth, and he's going to break 1 tooth, okay? But imagine if I did 6 anteriors. I did all 6, and he broke 1 tooth. What happened? A single tooth failure is most likely an occlusal contact issue. I missed something here. You missed something on your occlusal adjustment. What did you probably miss? At some point in the pathway, when he moved protrusively, probably the only thing that was touching was that 1 piece on the veneer or on the crown. All that force into a very small surface area, high stress, and you get a cohesive failure, right? So, restore a bunch of teeth, if they break 1, you missed the contact. You need to adjust the palatal of the upper to distribute the force. But this patient didn't just break 1, did she? She broke them all. And that means something different to me. When you have a multiple tooth failure, it's typically an envelope of function problem, meaning that you lengthen the teeth or you move the teeth into a position that now doesn't work with where she wants to move her mandible. They're in the way of where she wants to move. So what do I think this patient did? As I talked to her about her old composite veneers, I said, so what's different about the new veneers compared to what you had as the composite veneers? She says, oh, the new ones are much whiter. I don't think the color of them made them break. So what else do you think is different about the new veneers? They're longer, right? They're probably longer. And increasing their length, given where she wants to move her mandible, she keeps running into them, right? So I think that she has a pathway and an edge-to-edge wear problem. In fact, this is the upper initial cast that I asked the treating dentist to send me. Send me all of your old casts, right? Impressions, whatever you have, just send them over. So what are we looking for? We're looking for pathway wear, palatal of uppers, facial of lowers, and then we have a flat edge. She's actually coming out and crossing the edge, right? This movement pattern is one of the most dangerous. You're going to want to be able to recognize this on your patients. So what has happened for her? They made veneers on the upper anterior teeth. They lengthened the upper anterior teeth. And now imagine if she continued to do the old movement pattern. Here, she used to be able to get to the edge-to-edge position, and now there's a piece of ceramic in the way. And instead of changing the way her mandible moves, she's just continually doing it. And what's the risk? She broke the ceramic. All right? So these are really, they don't just chip restorations, they'll snap edges off. So you're going to want to be able to diagnose them before you start your treatment. Okay, so the initial thing you would probably be thinking, the veneers weren't strong enough, you need to use a different material, right? Make them into crowns. Oh, crown's not strong enough? Then do a monolithic crown. Monolithic Emax. Oh, that's not strong enough? Then do monolithic zirconia. I'll tell you what, we are making dentistry really hard for the next generation of dentists. We are, right? How many of you have tried cutting off a bonded full coverage lithium disilicate Emax crown and you have to replace it? Is that fun? It sucks, doesn't it, right? I would much rather cut off bonded zirconia because at least traditionally we haven't bonded to zirconia very well, so most of the zirconia restorations that I end up replacing, I can just make a cut over it and I can actually just split the restoration. But bonded Emax, you try to do that, you're going to break the tooth. So we end up having to do things like, anybody have like a hard soft tissue laser, like a water laser I+, right? Taking ceramic off is a whole different world when you're using the laser. It is a godsend for sure. Because what the laser will do is it'll go through the ceramic and it'll actually hydrolyze the water that's in the resin, and you can actually get right back down to your initial prep. And you can do so in a very small time compared to trying to prep the whole thing off, right? So it's an expensive piece of equipment, but it's going to pay for itself as we go forward in dentistry for sure. It's not a material problem, but we don't want things to break so much that we just make things stronger and stronger, and then we bond them in, and now whoever has to treat the patient next is going to have some big problems. Right? So maybe more importantly than just trying to cover our risk with materials is figure out how the occlusion can be adjusted differently. So this patient's teeth are in the way of where she wants to move. There's an envelope of function issue. Okay? So I need to provide a guidance pattern which minimizes interferences, but allows her to do her movement without risking the new restorations. Okay, so let's have a little discussion on envelope of function. So do you guys recognize this green diagram? Yeah? This is not the envelope of function, this is the envelope of motion. This was Posselt's diagram in the 50s. Have you thought about this from when you graduated dental school? Like, do you treatment plan a case and you pull out Posselt and say, what would Posselt do? This is the envelope of motion. So the reality is this is really not applicable to you and I because from those two dots down, that's all border movements and it's all opening, right? It's due to the ligaments and the joints and the muscles. That's all it is. But the very top of that, right? The top of that between those two dots, that one is interesting to me because you and I control that. That's tooth-to-tooth contact. So if I come in and I bond composite or I bond veneers, Posselt's envelope of motion is going to change. If you're an orthodontist and you're moving teeth and changing the interrelationship, you're going to impact the top of that. Okay? But if you think about it, that's a static relationship. I can put the teeth wherever I want. Orthodontists can put the teeth wherever they want. There's a patient on the other end. And I want to put the teeth in a position that neuromuscularly she's going to accept. Right? So we have a static position that you and I control. And then we have a functional aspect which is given to us by our patient, and everybody has a different movement pattern. So this was actually Gibbs Work back in the 70s, and what they were going to do is they wanted to make a really accurate study of how patients moved. They wanted to build an articulator that moved like the patient. So what they did is they took patients and they mounted a clutch, and they took 3 different types of patients. So a normal, healthy, class 1, no tooth wear patient. They took somebody with a malocclusion, and then they took a rehab group. They'd had a full mouth rehab at some point in time. They mounted a clutch onto the lower arch. And then what they could do is they could actually watch as a jaw tracker to see how chewing the same thing, how these patients chewed differently, right? And they could actually do this really accurately. So Frank showed you some videos this morning. That was taken from Gibbs' work. Okay, so I want to just show you some of the graphical tracings that they came up with. So this would be a normal occlusion. This is a patient chewing something, right? And it's the teardrop pattern. They open, they close, they move towards the food, and they close back down into the same spot. So you can see everything kind of coalesces back in the same position in their centric spots. Contrast that, though, to this patient. They're chewing the same thing, but their movement pattern looks completely different, doesn't it? In fact, look at the end point when they close back down in their occlusion. They're not closing back to a point, are they? They're closing to an area. And so you would be tempted to say that if you have somebody with a malocclusion and you're redesigning their occlusion, that you would want to shallow everything out, to give them an area to land, not a point to land. Right? The challenge is this. Although there were intergroup differences, like you see on the screen, there was also intragroup differences, meaning that not everybody with a normal occlusion or a malocclusion chewed like this. But now what we can do, at least in my mind, what we can do is we can define what the envelope of function truly is, and we can now apply it to our patients. Because I think it's made up of two things. It's what you and I do. What you and I do is create a dental envelope of function. We put the teeth into positions, or I restore them, and the pathway of movement is created by the contours of the teeth. I can move them wherever I want. I can make the disclusion however I want. But then there's a patient, and the patient brings in the dynamic positions, the neuromuscular envelope of function. It's the pathway of movement created by the patient themselves, right? So what do you want to see happen? You want to see that the dental envelope of function, the neuromuscular envelope of function are in harmony with each other, right? Where I put the teeth is within the confines of where the patient is moving. Because if that happens, the risk of breaking things goes down. Problem is that doesn't always happen. Okay? So this is a patient who comes in, maybe your patients do the same thing. They come in with a treatment plan already. She has a plan that she says, I don't like the way that they're worn differently. This is old composite. I want to have ceramic veneers, and I want you to lengthen them so they're all kind of the same. And I said, that's a great plan. Like, where did you get your... She goes, oh, I'm not a dentist. But actually, it is a solid plan. Okay, so now, what's the risk? Why are the right central and lateral more worn? Is she a pipe smoker, right? Does she hold her pipe there? No. Which means that where do you think her preferred movement pattern is? Probably some sort of a right protrusive. So what am I going to do? I'm going to take old composite off, I'm going to refine the preps, and I'm going to do exactly what she wanted me to do. In which case, what have I just done? I've now lengthened the teeth on the right, where she used to like to move, and what am I going to hope? I'm going to hope that when she starts to do whatever movement pattern she's doing, proprioceptively, it feeds back. She doesn't even have to be aware of it, but it feeds back, and she goes, oh, there's something in the way, and then she moves the movement pattern. She changes. She doesn't go to that position anymore. Because if she alters the way she moves, now my ceramic is safe. But what else could happen? She continues the same movement pattern that she did, and now what's in the way? Ceramic. And if she doesn't reprogram the way she moves, I'm now at risk that my veneers are going to break. So are we able to predict who's going to adapt and who's not? I mean, that would be crucial, because I would charge differently. If you're not going to adapt, then I maybe change materials, and maybe I charge you differently because I know I'm going to have to do them over again. So this is actually a cool paper in my mind, because what they did is they're kind of asking that question. They took patients with severe wear. This is a patient of mine. They did a jaw tracking study on these patients. Same way I showed you. Before they did anything, they had them chew. They looked at the way that they chewed. Then they restored them. and they brought him back 3 years later, had him chew the same thing. What are they looking for? The changes in the movement pattern when you had the tooth wear versus when you now have a completely different occlusal design. They're asking to see, did these patients alter the way they moved? Am I going to be safe? Okay. So it wasn't a huge study. They had 9 patients total, or 11 patients total. At 3 years, they got 9 of them back. Okay. And this is actually a quote, a direct quote from their paper. They said that the masticatory cycle adapted to the altered form of the occlusal surfaces. What are they saying? That the patient changed their movement pattern. And you go, great. That means that we're safe, right? Now, do I believe this? I believe part of it, right? Because they have to change their movement pattern. At least to a degree they do. Because if they don't, how do they chew? How do they speak? So they have to change the way they move because we have teeth in different positions that they weren't there before. But if you look deeper into this paper, out of the 9 patients that they got back, 3 of them had problems, continually had problems. 2 displayed wear and fracture or restorative materials, 1 snapped off a 3-unit bridge. If you truly adapted and changed your movement pattern, then you shouldn't see these problems, should you? Because they would have changed the movement and not done the same destructive movements. So the reality is, a third of these patients that they got back, in my opinion, didn't change their movement. They probably continued to do the same movement pattern, and now whatever you and I do restoratively is at risk. So this is, again, back from Gibbs's work, and this is a chewing cycle from looking at the patient from the front, chewing the same things that the other patients chewed. What looks different about this to you? To me, that influx of lines that's right there that all follows the same pathway, what do you think that's caused from? When they're chewing, when they're either opening or when they're closing, they're actually running into their teeth. And not just touching their teeth, they're running in and sliding along that entire surface. You all just had lunch. When you're chewing, do your teeth actually slide against each other every time you open and close? No, because there's some food in there. And proprioceptively, you know where your teeth are, so you're not actually, they're slowly missing each other. So what does this patient mean to me? This would be one of those 33%, that they didn't change the way they moved. They continue their movement pattern, and the restorations are in the way. And if you keep hitting them, they're either going to wear, chip, or break, or get loose in the periodontium. Okay? So let me show you this, the idea about can we predict who's going to change their movement pattern or not. And I'm going to use this patient because we have some significant follow-up history. Okay? So this patient was restored and seen at the University of Washington Grad Pros Clinic. And he was actually treated there the first time before I was a student. Okay? So this is now in the mid to late 80s. You can see that he's had kind of a piecemeal rehab and lots of ceramic fractures. So he's in need of a new rehab. So he's assigned to a grad student. He's managed by a faculty. They do the full rehab, and they're concerned about wear. And how do I know they're concerned about wear? Because they said, you need to wear 2 night guards. 1 is not enough for you, you should wear 2. Okay, so he actually does wear these. He religiously wears these every night. Okay, now, one of the things that I thought they really did well at Washington's grad program is you know it's not going to last forever, right? Anything we do doesn't last forever. So what we would do is we would actually follow our patients and we do short-term and long-term recalls. Short-term recall was 3 years at the minimum. Long-term recall had to be 7 years or greater. So he's going to come back for a 3-year recall. But here's the beauty of how it worked. A grad student brings them in, they do all their documentation of here's what they look like 3 years later. They present it to the students and they say, okay, here's how they initially presented 3 years ago. Here's what they were going to do. Knowing that we're 3 years smarter, would we do it the same way or would we change it? And what do you think is going to happen if they restored it that way, right? That's really it's like the crystal ball. So then they say, okay, here we are, 3 years later, he comes back in, and he's got some problems. He's got some ceramic fracture. Okay? That's actually not the big problem. The big problem is this whole piece is now removed. 3 years. Okay? Now, here's the good thing. The grad student that restored him has great slides, great documentation to go back to wherever they're from and say, look what I can do, not knowing that he destroyed it in 3 years. So now it gets assigned to another grad student. Right? Here's grad student number 2. Now, this is around the same time that I'm in the program, and all of those teeth that were fractured have to be taken out, and he's going to be treated in the perio clinic. So nothing happens fast in an educational standpoint, right? So they got to take the teeth out, then they got to graft it, and they got to put implants in. So I'm still at the program, and these are the next grad students' provisionals. And the provisionals are a metal composite provisional. And that's actually a chrome cobalt partial denture as a provisional. So you go, why would somebody go to such great lengths in the temporary phase? Because the temporaries kept breaking, right? So this guy actually bought the grad school, our little clinic, he bought us a microwave. So when he came in to get his temporaries fixed, because he was in there every week, he could heat his lunch up, right? So grad student went ahead and did this. This is Iñaki Gambarina, probably one of the most talented clinicians that I know. Now, where did I come in? I came in to help seat the partial because he's now graduating. He still hasn't, loaded the implants. They're underneath that partial. So I'm going to come in, help seat the partial. Now he's my patient. Okay? So 3 years, he broke the rehab. In 3 months, he snapped off the teeth. And you go, come on, it's plastic teeth. Of course he's going to break them, right? But that goes back into the material mindset. It's not a material issue. I want you to look closely at the amount of vertical overlap that you see on the left versus the right side. Do you see that he's got a little bit deeper overbite on the left side versus the right side? It's hard to predict who's going to adapt and who's not going to adapt. So what do? This guy's obviously not adapting. Anything that's in his way, he's removing it for you. So we identify his movement pattern, right? Is it erosion or is it attrition? If it's attrition, my risks go up. How are they moving their mandible? Their neuromuscular envelope of function. And then, if I'm going to alter it, I need to be able to try it out. So what do we look at to determine what they do? We look at the wear facets. It's a great indicator. On this patient, it's not so much wear facets as it is fracture. Again, another indicator. We could look at mobility. Mobility not due to periodontal attachment, mobility due to overloading the attachment, so fremitus. All of these would be markers for me about where patients are moving. And then, if we're going to change the position of the teeth, right, change the dental envelope of function, I have to try it out because I don't know how they're going to respond. Are they going to be that 30% that continues the movement and now I'm at risk, or is it going to be the other 66%? So how do we try it out? We physically have to design it in the patient's mouth. So we use resin, we use provisionals, and typically that means we're going to follow it up with some sort of an equilibration. Right? Now notice what's not on that screen for my trial therapy. You don't see a splint. I hear people say, well, I'm going to do a splint and I'm going to work out the occlusion in the splint. Great. If you want to do that, by all means. But understand that the only occlusion you're working out is the splint occlusion. Because there's things that I can do on the splint that I can't do with the tooth-to-tooth relationship. So I use splints, but I use them to help muscle or joint problems. I don't use it to design an occlusion. For that, I actually need to physically do it. And then what I'm going to do is I'm going to look at their response to it. Did it break? Did it chip? Did it come off? Because if there's a problem in the trial therapy phase, I would like to change the anterior relationship before I get into ceramics. Make sense? And how do we determine what to change? Remember, ask yourself how many teeth failed. Okay, so let me just give you an example of trial therapy. This is a patient of mine who decided he could bleach his teeth, exhausted that, and he has these 2 veneers. And he comes in, he says, I want you to redo the veneers on the two centrals. And I said, okay, I can do that. I can make a match. I said, but tell me, do you see how this one on the right is all slanted? He goes, yeah, I hate that. I want them both the same length. I said, did you let them put that in like that? He goes, no. When they were done, it was maybe 7-10 years ago, when they were initially done, the edges of the two centrals were the same. And then he goes, what happened is after a few months of wearing them, I chipped it. I chipped that right one. So I went back to the dentist that did them, and he said, yeah, it's not big enough to replace, it's not big enough to repair, so we'll polish it. Okay? So he polished it, got a little shorter. And then he goes, yeah, a few months went by, and I chipped it some more, went back in, same story, so they polished it some more. This is liked ever since. I want to know, why chip? If I come back in and I lengthen that edge, and he does whatever he did 7 years ago, my veneers are going to soon look like this. So, if I look, it is left and right lateral. Notice that when he's edge to edge on right lateral, he's got the canines touching, but he's also got the lateral touching and the distal incisal edge of the center. Now, what's going to happen if I come in and redo those veneers and lengthen the distal incisal edge? And I move him back into the same position. The only thing that's going to touch is that veneer. And the risk would be it's going to break. So what I don't know is, I don't know if he's still going into this position or if these facets are historic. So I'm going to change the anterior relationship in trial therapy to accommodate what I think might be a risk factor for me. What I wanted to do was I wanted him to do some minor ortho on the lower and take that lower canine and move it out into the arch, because doing that, all of a sudden, you're going to discollude the central. But he says, nope, don't want to do that. I said, okay, then what I need to do is I need to actually bond some composite onto your lateral and your canine to change the disclusion to clear up the distal edge of the central. Right? They're worn. It would look better if I did that as well. So that's my trial therapy. And then what I'm going to do is I'm going to watch to see how he does with it. Does it chip? Does it come off, break? Does he start having muscle problems? Because if the answer to any of those is yes, then I need to redesign it before I move into my veneers. Make sense? Now, the typical question I always get is, how long do you have to do your trial therapy? Tell me how concerned you are. All right? I would say that if you're concerned about your new design being successful or not, 3 to 4 months in provisionals or in plastic, and you have success, I'm really comfortable moving forward. All right? So I bonded the teeth and I let him go for 4 months, and he comes back and the composite on those two teeth looked as good as I put him in. They didn't come off. He had no problems at all. So now I'm comfortable taking the veneers off and starting my restorative treatment. And when I prep them and provisionalize them, I'm now starting again my trial therapy, because now I'm proving to myself that yes, I can get that distal incisal edge lengthened and he's not going to break it. But I don't think he's going to break it because he did the composite really well and I had room. So there's the composite on those two teeth and my provisionals. And then it's just a matter of changing this out into ceramic. So here's the new 2 units of ceramic for my anterior veneers. That's the idea of trial therapy. Okay? All right, let's go back to our patient, the one that broke everything in 3 months. This is trial therapy. It's expensive trial therapy. So I have to think to myself, how did they get into this position? Like, how did they not see this in their provisional phase? And my thought would be one of 2 things happened. Maybe they made veneer temps, but the veneer temps were made in the same position as the composite veneers, which had worked for so long. And it wasn't until it got to the lab bench that the technician goes, it would be better if we actually lengthen these. They'd look better. That could be one. 2 could be that I've heard of clinicians not temporary veneer. Put a little suck down on and they're good to go until you get the restorations back. So one of those 2 things had to have happened. Otherwise, they would have had some serious problems in the provisional phase. Okay, so now she's sitting in my chair. 6 teeth are restored. She broke 5 of them. It's an envelope of function problem. What do? I want to make this one easy. You had composite veneers, 16 years. They were great. They were shorter. So let's just shorten these new veneers and make them the same length as your old veneers, and all of a sudden, problem solved. She goes, no, I like them longer. And she goes, in fact, you know what I'd even like more? They're kind of sticking out a little bit. So if you could bring them back, then I would love them. What is this going to do, bringing them back? That's going to restrict her even more, isn't it? Okay. So if we can't get her back into what was being successful before, I have to change the anterior relationship. I have to change the overbite and overjet relationship of her anterior. And that leaves me only with 2 treatment options. Okay? So I said, when you have a patient with edge-to-edge and pathway wear, that combination is what she has. That's a high-risk patient. They're going to break something. They need classic shallowed anterior guidance. You know what that term means, shallowed anterior guidance? Shallowed anterior guidance is less overbite with more overjet, or a more shallow disclusive angle, right? That's shallowing the anterior guidance. If you don't give somebody shallowed anterior guidance that has edge and pathway wear, you're asking for problems. So I need to decrease the overbite and increase the overjet. How do I do it? I could open her vertical, right? Because what happens when you open vertical dimension? The mandible drops back, so your overbite gets less, and it actually drops into more of a class 2 relationship, so your overjet gets greater. So that's one option. The other option is I could alter the incisal edge position of the lower anterior. Just move it apical, because when you move it apical, you also get those same 2 benefits. How do you decide what to do? You guess. You guess and you do your trial therapy, which means that you need to have the recognition of here's the movement pattern, here's what I think I need to do. You open the vertical dimension however you think, you change the lower anterior position however much you think, and then you try it out and you see how well you guessed. Now, it's not a guess, it's an educated decision-making process, but it's an educated guess. All right? Now, is there any way to swing the benefit to our favor? That I know that if I shorten the lower anterior this much, or I know that if I length or open vertical dimension this much, that's going to work. Yeah, there kind of is. What did she have so successful for 16 years? Composite veneers. Okay, so here's the old cast. These composite veneers were working. So what is it? That's your dental envelope of function, isn't it? It's the position of the teeth. The position of the teeth in an environment that's working. So if it's an environment, what else is it? It's an analog of their movement pattern, right? It's in harmony with where she likes to move. And if you take the current upper model and the pre-treatment, you can see that they did, in fact, lengthen the anterior teeth. Now, here's the beauty. You want to know how much to open the bite. You want to know how much to shorten the lower anteriors. You actually can create the answer exactly how much you need to do by using the knowledge contained in that upper cast, because that has neurologic and dental envelopes of function, right? So we go old school pros. When you have a pathway wear patient, they need more freedom. How do I assume, or how do I create and know that I'm giving them back more freedom? I make a custom incisal guide table. Custom incisal guide table is basically an analog of their movement pattern. That's all it is. So you would mount the case and you would put some resin onto your tray and you would move the articulator left and right, back and forth, and that pen is going to be shaping that acrylic. That's an analog of their movement pattern. And then you're going to use that in your new occlusal design, right? So as that material's going through its set, when I have the upper initial cast on, That pen is shaping that guide table. It's creating and it's giving me the edge-to-edge position. This is her dental and neurological all in one. Now, what do you think is going to happen if I take this upper cast off and instead put on her new veneer cast and I use the same guide table? The pen is going to touch that guide table as long as the teeth are touching natural tooth structure. But as soon as that lower anterior starts to touch the veneer, that pen is going to lift itself up off of the guide table and no longer touch. Those differences in positions is what you need to account for to decrease the risk of her breaking the restorations. Does that make sense? So I said that there's two options that you could use. You could open the vertical, restore a lot of teeth, or you could change the lower incision. How would you use the guide table depending on what you wanted to do? You would start your aesthetic wax up. So I'm going to lengthen the edges. I'm going to bring them back like she wanted. But I haven't waxed the occlusion yet. So let's say that I was going to open her vertical, or let's say the upper arch. How would I know how much vertical dimension change to do, right? That's the big question. Imagine that that's a wax up on the very left of that screen. I wax the edge, I change the position, and in the wax up, I'm going to move the lower anterior into an edge-to-edge position. And when it goes into the edge-to-edge position, what happens to the pin? It no longer touches the guide table. So you want to know how much vertical dimension you need to open? Undo the pin, drop it down until it touches the guide table, and lock it up again. You have your answer, whatever that is. Now, what's going to happen when you drop it back into MIP? You no longer have MIP, right? Because you just opened the bite. So you wax contacts in, and then you wax the palatal so it matches the existing pathway that she has. And you use the guide table to do that. I'll show you what that looks like. And then you actually remove some wax and give them back a more shallowed guidance. Give them back more room. But all the thought process is right there in that guide table. So what would be the other option? The other option would be changing the lower anterior. So how would I know how much I would want to shorten it or intrude it? Again, you're going to intrude it or shorten it to the point that when you bring the edges out into a protrusive edge-to-edge, the pin touches the table. However much you have to take off that lower anterior to get that pin to touch is what you need to do clinically. So the answer's there, we just need to know how to find the answer. Okay? So now, which option should we choose? How do we choose one of the options? In order for us to choose which option is the best, we're going to look at the lower plane of occlusion. Right? When we treatment plan patients to get occlusions to work, I want to have levelness to the plane of occlusion. Right? When you set a denture, you don't set a denture with lower anteriors that are jacked up, right? Big curves of speed. No, you set a level plane of occlusion. I need the same thing when I'm actually working on my patients. Look at her lower plane of occlusion. What do you notice? Lower anteriors are stepped up. So if the lower anteriors are stepped up above the posterior occlusal plane, my answer would be do whatever you need to do to level the lower anteriors. Orthodontic intrusion, great.